Lauren Summers. I'm Senior Director of Lifelong Learning and Travel at the Yale Alumni Association. And this is the Yale Alumni Academy's 5th anniversary of Climate Change Conversations. This is a series of presentations that we offer annually, generally timed with the COP event. And we want to highlight the scholarship of Yale faculty and centers of research around issues related to climate change. Our presenter today is Dr. Jodi Sherman. Jodi is Associate Professor of Anesthesiology of the Yale School of Medicine, Associate Professor of Epidemiology in Environmental Health Sciences, and is the founding director of the Yale Program on Healthcare Environmental Sustainability at the Yale Center on Climate Change and Health. Dr. Sherman also serves as the Medical Director of Sustainability for the Yale New Haven Health System. And I'm going to pass it to Dr. Jodi Sherman, who has a wonderful presentation prepared for us. I remind you all that at the end of Jodi's presentation, we will have an opportunity for a question and answer and a healthy discussion on the topics that were presented. If you have questions that come to mind during the presentation, please do put those in the Q&A box and not in the chat. The Q&A box helps us keep track of everything you asked and make sure that we answer all your exciting and interesting points. And without further ado, I'm handing it over to you, Jodi. Welcome and thank you for being here today.
Thank you so much for this invitation. And just as a sound checking, you confirm, and a visual checking, you confirm that you can hear me and see my slides in proper mode.
All good.
Very good. Well, thank you very much for this privilege of presenting to the Alumni Association today. A subject I've been researching for well over 15 years now, and that is environmental sustainability in healthcare. And the title of the talk is really meant to reflect not only do we have to add this planetary health lens to healthcare, but that we're in a unique situation in healthcare that, we are taking care of the patient in front of us, but that has implications for public health that really we weren't taught in our training. And that's something that we need to think about. And so when I think about my own journey, which was a bit convoluted coming both to healthcare and to anesthesiology and then to public health, I really start the conversation during my residency training in anesthesia, where it was so much fun taking care of patients for the first time, really starting to see my career come together. But it's just so obvious that we're using so much stuff, we're wasting so much stuff. It's coming from somewhere, it's going from somewhere. We're clearly causing harm to the environment and to public health while we're taking care of patients, which is against our mission to do no harm. But there was no information on how to do better, and other than to just waste less stuff, which is important, but it's not nearly enough to guide practice improvement. So I actually made a pact with myself to try and understand and do better. Otherwise, I couldn't carry on continuing taking care of patients. And it really is this expanded mindset of not just what's best practice for the patient in front of us, but what about public health and planetary health at the same time. And so from today's talks, I hope you'll be able to, by the end, identify a relationship between healthcare pollution and disease burden. We're causing harm measurable harm to patients. I'm going to summarize some of the latest healthcare pollution findings. And then for those who work in practice and policy and innovation, describe some opportunities for improvement. And so why sustainability in healthcare? Well, we can take a step back and say that, we know that pollution is a leading cause of morbidity and mortality, responsible globally for 9 million premature deaths, or 16% of premature deaths are due to pollution. And against our mission to do no harm in healthcare, the Hippocratic Oath, ironically, healthcare is one of the leading emitters of environmental pollution. And reducing pollution, healthcare pollution, can improve the triple bottom line, some variation of the best care for the most patients at the least cost. All those things can be in alignment and improved through using the sustainability lens. And then importantly, I think everybody at some point touches healthcare. If you don't practice it or work in a field that is related to the healthcare industry, then at some point you or your loved ones have used or will use the healthcare system. And so everybody at some point in their life cares about healthcare. And so if we can change healthcare, maybe we can rapidly affect other sectors of society. Now, something important, if you're not familiar with what are now characterized as the planetary boundaries, and that is the geophysical dimensions that support life on this planet have been described, and transcending those boundaries reduces, or if we reach a tipping point, can dramatically reduce the planet's ability to sustain life on this planet. And so those are known as the planetary boundaries. And so climate change, ocean acidification, freshwater withdrawals, land conversion. So you can see all the dimensions that have been described, and we are transgressing those boundaries. Now we can reduce healthcare pollution by providing less care. That's not the goal. The goal is to elevate access and quality globally to achieve the Sustainable Development Goals, universal health care. So that means we have to meet some foundation to meet everyone's needs. It's called the social foundation. And so, somewhere in between what's been characterized as the ecological ceiling, the planet's ability to regenerate itself, and the social foundation, so that everybody has a right to be able to thrive as a society. So what's been described in between that is a safe and just operating space. And so that's really what the goal is. And so, the big focus here is mostly on climate change, but not exclusively. So you will hear me talking a lot about greenhouse gas emissions, mainly because they're relatively easier to quantify, but it's not the only type of emission of concern. But healthcare contributes a lot to pollution and to climate change. And why is that? So hospitals run 24/7, got very energy intensive buildings, including to run the HVAC systems, the heating, ventilation, and air conditioning, and the humidification. So it's tightly controlled in the healthcare setting. We have high tech diagnostic therapeutic equipment that is usually on and running 24/7. Something unique about the healthcare industry is that we have to be concerned about infection prevention, so reducing that risk and also regulatory requirements around that. There's no other industry like it. The food industry is sort of, but not not the same way. Some things need to be sterile in healthcare, so we've got very unique requirements around infection prevention and control. Also, healthcare is an enormously complex environment. So, regulatory complexity that to adhere to results in a lot of human resource and generates a lot of waste by trying to adhere to it. There are also business models that, frankly, benefit from waste. And so, those are some more added complexities. And also, this culture, especially here in the United States, we're very wealthy. um, Excess is not even noticed by us unless one has spent any time in a low income country, done a medical mission. It's really, or even gone on an extensive camping trip. Like there's, in general, lack of appreciation of how excessive we are in our day to day lives. And we think that disposability is normalized. Our to go cups, our to go, tableware and plates, all that we think is normal to throw away. And healthcare, everything you're looking at on the screen here, those are all disposable. So disposable linens, disposable surgical instruments. I mean, it's crazy. So, the disposability, especially in healthcare, is really rather outrageous. And if anyone's works in a healthcare system in a clinical setting or has been a patient recently, it is really quite obvious. And then we also have this social mission. We are responsible for the patient in front of us. That is the priority. And so, this thinking about, well, what about the communities we serve? What about public health? What about environmental health? Since our health is dependent on environmental health, this is a new way of thinking. We've historically gotten this pass for being polluters because of our social mission to take care of patients. And we really need to expand our mindset. It's both and, it's not either or. And even though this talk is mostly about climate change and greenhouse gases, it's not the only thing that we're concerned of. There are over 100,000 novel entities in existence. These in the marketplace, they are poorly regulated, unlike the pharmaceutical industry, where safety and efficacy have to be proven before a pharmaceutical is released to the marketplace. Industrial chemicals, it's the exact opposite. You have to prove harm to get something removed. And that is a problem because then the burden of proof becomes as complicated as it was for tobacco. It was a very long battle to be able to say scientifically that smoking cigarettes causes lung cancer. Why is that? Because of all the other confounding factors. And so we've got a similar problem with all these chemicals in the environment. That's why there's this movement, at least in European law, toward what's called the precautionary principle, which is you should prove safety first. And in the absence of that, then be more cautious and don't just approve things. And then I didn't think about this in any of my training, but the healthcare sector is enormous, and we are a leading purchaser of chemicals. I never thought about how my practice, just showing up and taking care of my patients, was part of this larger complex system that was contributing to this problem. Nobody, unless you study, economics or environmental engineering, like these sorts of concepts are not really conveyed. So I think we all have to be aware that we are part of this drawing from this large system. So that's about introducing to the marketplace. What about on the waste regulation side? Pharmaceutical contamination is a global issue. Drugs are routinely detected in our tap water, higher concentrations around manufacturing and sewage plants. Our sewage treatment plants are not designed to handle most drugs or the transformation products. It's possible through reverse osmosis technologies. There are more and more technologies that are making this better, but really we need effluent controls at the point of leaving healthcare facilities, at the point of leaving manufacturing facilities. We're not there yet. So our sewage plants are not really treating this stuff. And again, we as a healthcare system are a leading purchaser, not only of chemicals, but obviously pharmaceuticals. And the deal about them being in our drinking water is that they're essentially unregulated. No level, any level is pretty much safe because they're such small quantities. They're not therapeutic quantities. It's not like you can see a dose effect. The quantities are so small, but there are numerous exposures of numerous pharmaceuticals, and we do not know the effect it's having on humans, especially developing fetuses, young children who have more exposure based on their body composition, water composition, and also that they're higher metabolisms. And we do know that we're seeing effects on aquatic life. So it stands to reason that it is harming us. And again, we're contributing to this problem by all the medications we're prescribing and not to de-prescribing all the medications we're wasting. So we need to really think strongly about how to make this better. And so turning back to climate change, you're seeing on the left a famous projection, this one particularly from the Climate Action Tracker. What you're seeing are different trajectories based on no climate policies on the left, and the spread. The spread is the level of uncertainty, so you can just go in the middle of that. But what happens without any climate policies? We're going to see a warming between 4 and 5 degrees centigrade by the end of this century. Under our current policies, between 3.1 and 3.7. And just pledges to the Paris Agreement now, not even actual policies, but pledges are still not enough. That those only get us to 2.6 to 3.2 degrees centigrade. And really what the Paris Accord tells us is to limit to 2 degrees centigrade, aim for 1.5 degrees centigrade emissions reduction to that level of warming to avert the worst predicted harm to civilization. It's not like life is going to stop. Life will continue on. Humans will, probably, continue to exist. But civilization as we know it is not going to unless we make dramatic changes. We are already seeing harm to society, to human health from the 1.2 degrees centigrade we've already seen. And we are likely to reach that 1.5 degrees centigrade threshold by 2030. We've actually already transiently transgressed it. This is average surface temperature across the globe. We've already transiently transgressed that. And so the recommendation, in essence, in short, is that we need to have our emissions by 2030 and get to net zero by 2050. And 2030 is not that far away. I've been giving this talk for several years now, And the answer is, oh, that's hard. We'll get to it, and time is ticking. It's getting harder and harder to achieve these goals. And again, it's not like we're going to instantly disintegrate and die. It's that life on this planet is going to get more challenging. It is actually possible within the laws of chemistry and physics to achieve this. It really is about political will. And in the words of Deborah Roberts, the co-chair of the IPCC back in 2018, the next few years are probably the most important in all of human civilization. And so what does climate change have to do with health care? This talk is about health care. Well, there are direct effects and indirect effects and modifiers by social dynamics that then lead to health impacts. So the direct effects, things like storms and droughts and floods and heat waves, those cause direct injuries. There's also indirect effects. So water quality. So example, if the municipal sewage plant is flooded and then that gets into the municipal water drinking water, or if you have well water and that gets contaminated, so or salt water, if you're on the coast, that can get into the drinking water, so affecting water quality. Air pollution, wildfires is the most common example that we're seeing. Wildfires in Canada affecting the air quality here in Connecticut and New York, um, and so forth. And social dynamics, and not everyone is affected equally. The very old, the very young, women are disproportionately affected, those with disabilities, those who have chronic illnesses, those who are poor and who are less capable of making urgent adjustments. So, for example, evacuations during Hurricane Katrina, those who didn't have cars, who didn't have money to stay in hotels, to leave, that affects the kinds of harms that you see from climate change. And so health effects anywhere from physical injuries to mental illness, undernutrition from drought leading to crop failures, air pollution from wildfires, exacerbating cardiovascular disease, so MIs, heart attacks, and strokes. All these are things that we are already seeing measurable harm, and then heat impacts and acute kidney failure from dehydration in agricultural workers who are more exposed to extreme heat days. All this is measurable. It's all happening. There is no country that's not affected, and all of us are affected if food doesn't make it to our table. No matter how removed and how wealthy we are, if food doesn't make it to our table, we are all going to be affected. And so I just discussed the altered and increased disease burden from climate change. Other things we're seeing that impact health systems include displaced populations. So patients can't, if your facility is destroyed, you have to move to the facility at the next town. And the same is true for staff. And then that affects, even if you're at the penumbrum outside the affected area, your care is going to be affected by the displaced populations, as we've seen with the pandemic. Structural risk, so that affects the physical buildings of our healthcare facilities, also the utilities, or energy, or water, or sewage, and our roadways, the transport, how we get to and from hospitals, and how our how our supplies get to and from hospitals. So these are some of the ways that health systems are impacted by climate change. And just some examples, and like I gave up trying to keep this slide updated, but Hurricane Sandy on the left, so you're seeing images from New York City and Langone Medical Center being evacuated. On the right, Camp Fire in California and Paradise, where the Feather River Hospital was leveled to the ground, raised to the ground. You're seeing patients evacuated within an hour of that facility catching fire, and eventually was raised to the ground. This is real stuff. This is in the United States, and most recently, so Hurricane Maria wiped out the Baxter plant in manufacturing plant in Puerto Rico, or the Baxter plant that was just wiped out on the mainland in the south from Hurricane Helene. Same thing. Baxter plant that was responsible for 60% of the United States production of IV fluids. And even if you aren't feeling it, I assure you, our health systems are suffering right now. We are rationing. We are rationing our IV fluids. This is a patient safety concern because we are changing our practices because we are rationing. It's leading to cancellation of elective surgical cases. And so, even if you haven't had a direct health impact, you may have your surgery canceled because of IV fluid shortages. So we are seeing this now across the United States. And then something from an example from Hurricane Maria, where we saw this paradoxical increase of drug waste. So also on the island of Puerto Rico, the only site for manufacturing these 2 ml vials of spinal bupivacaine that we use to do spinal anesthetics for predominantly for women who are having emergency cesarean sections, but also we do them for some surgeries as well. Those were gone. So this 2 ml vial, 2 milliliter vial had to be substituted with 30, 50 ml vials. And for patient safety reasons, we have to throw the rest away. Or you have to develop a whole new infrastructure to sterilely split those, which we can do, but takes time. So you're seeing breaches in safety, increased waste, and then new procedures having to be implemented, all because of these shortages. So this is real. This is affecting everyone, and may or may not be making the news. So that's a bit about how climate change is impacting healthcare. But now, what does healthcare have to do with climate change? So flipping the script. So this is our work with the Lancet Countdown on Health and Climate Change. We have looked for, this is now our 6th year of participating in this annual report. The healthcare sector itself is responsible for nearly 5% of global greenhouse gas emissions. It stands to reason. We're 10% of the global economy. We're 20% of the US economy. It is an enormous industry. It stands to reason that there's a lot of pollution coming from healthcare. And this global pollution, 1/5 of that is coming from the United States, even though we're only 4% of the global population. 20% of these emissions are coming just from the United States. So we're doing something differently here and not necessarily in a good way. Now, if we had the best health outcomes, one might make the argument, well, we're doing something better in the United States until we figure out how to make our processes more environmentally friendly. We're getting better health outcomes. And so we might, again, get a pass. But that's not the case. So on this slide, what you're seeing is the per capita healthcare greenhouse gas emissions plotted against some measure of healthy population, in this case, healthcare access and quality, healthcare access and quality index from the Institute for Healthcare Metrics at the University of Washington in Seattle. And so we can see that there are several countries whose health systems are performing much better than the United States. And for far fewer emissions. And so the good news is that there is opportunity for us to reduce our emissions and maintain or improve our access and quality. At the same time, there are many countries who are performing much worse in terms of healthcare access and quality. So we would expect them, as is their right, to expand their healthcare access and quality, even at the expense of more emissions. But what we don't want is for them to just emulate what we're doing in the United States. There has to be some sort of leapfrog as we help them to develop. If we're going to achieve the sustainable development goals, including universal health care, if we just expand care as we're giving it in the United States, we're all going to be in trouble. So we need to do it differently. We know that 1/4 of services globally are deemed low value or inappropriate, so we have to address that waste. And at the same time, half the world lacks access to even essential health services. So moving those resources to where they're better used. And in the United States, 11% of the population is uninsured and half is underinsured. So even within the United States, so much waste, and at the same time, we're not meeting our population needs. And so we've calculated about 400 kilograms per CO2 emissions is kind of the break even point. So in the US, we're about 4 times that. So we've got a lot of work to do. And so there are other types of emissions besides greenhouse gases of concern. And what we then did was looked at the disease burden stemming from healthcare. And so what we found is that in the US, all emissions added up, both greenhouse gas and non-greenhouse gas, nearly 400,000 disability-adjusted life years are lost due to healthcare pollution, especially from air pollution from particulate matter. And the number one cause of emissions of greenhouse gases in air pollution is combustion of fossil fuel. So we need to clean up our energy sources. And this disease burden is actually don't mean to confuse people, but it's actually in the same order of magnitude as deaths due to medical errors as first reported by the Institute of Medicine. What you're seeing on the right, anyone in healthcare is familiar with, is landmark publication to Air is Human, which was produced by the Institute of Medicine in 1999. We thought we were doing healthcare safely until this report came out. What it revealed was medical errors are a huge problem, and we need to figure out how to do a better job. And when this publication came out and that fact came out, it sparked a patient safety movement. Everything we do now is through a dedicated lens. We have structures in place, we have institutions in place, we have quality measures in place to make sure that we are doing our best to prevent every preventable error. Not everything is preventable. Those things that are preventable, we have to make every effort to try and prevent them. Change the way this report changed the way we practice healthcare in this country. What we found is that the actuaries say about 10 years of life are lost due to per death. So if you multiply by 10, you see we are in the same order of magnitude as the dailies lost due to healthcare pollution. Same order of magnitude of harm from healthcare pollution. So what we're trying to say is that pollution prevention is a new patient safety movement. As we approach everything in healthcare through the patient safety lens, we should also be adding that pollution prevention lens. Globally, it's 4.5 million disability adjusted. This is for the US. This is globally 4.5 million disability adjusted life years lost. And 1/5 of that is coming just from the United States. So now need to know where the emissions are to be able to focus attention, right? So we've looked at that as well. And many studies now come out and have painted a very similar picture. You're seeing one on the left from the National Health Service in England. Overall, about 70 to 80% of emissions are coming from the supply chain, the goods and services to run that healthcare. And the big outliers in healthcare are pharmaceuticals and chemicals and medical equipment, and also categorized a little differently over here, anesthetic gases and metered dose inhalers. So these are things that we have direct control over as clinicians. And so again, tells us where to focus our attention. And for non-clinicians in the audience, I'm sure you can see yourself in this picture as well, whether it's from food and catering, business services, transportation, so forth. Everyone has a role here. On the supply chain side, for the pharmaceuticals and medical equipment, the two general ways I like to think about how we can have impact. One is to address waste, meaning inefficiency. Clinicians, we control how much stuff we use. Administrators and regulators also have a role to play in that. So reducing waste and inefficiency. Another big way of thinking about it is the embodied pollution, what's in the stuff that we use. We don't have control over that as end users. That's really up to the manufacturers and the regulators that control what goes to marketplace. And actually, we do have some control over what's embodied by using our purchasing power, leveraging our power through purchasing organizations to say, we're gonna buy products that are less polluting, and we're gonna demand standards and transparency around that. And that's gonna help shift the marketplace. So I'm gonna come back to the issue of healthcare acquired infections. It is all of our jobs in healthcare. This is one of the preventable medical errors that I mentioned. Healthcare acquired infections are a huge problem, 700,000 annually in the US alone, the number one adverse event globally. 75,000 premature deaths annually in the United States, costing up to $7 billion in excess healthcare expenditures, as then we have to treat those infections and add more care, and add more hospitalization time, add more surgical procedures to address healthcare acquired infections. So we're increasing our costs at the same time. It is all of our job in healthcare. Everyone must go through that safety lens, and that includes preventing healthcare acquired infections. Unfortunately, what we're seeing is this trend toward single-use disposable items and also drug waste. For example, whether or not something that is open but not in a sterile environment can be split between two patients. So what we're seeing is a lot of device waste, a lot of drug waste in the name of infection prevention. It is everyone's job to prevent infection prevention, but what we're seeing is a non-evidence-based trend in this direction. And this is causing a lot of trouble, including the fact that we are now so dependent on single-use disposable devices. We are now vulnerable. So what you're seeing are images from the COVID-19 pandemic at the very beginning, when we ran out of supplies. And this is not a developing country. On the left, you're seeing, this is in the US, and the left is a hospital in Brooklyn, New York. On the right is in London in the United Kingdom. So, this is everyone is affected, so nobody is immune from supply chain interruptions. And what we're seeing here is because of a dependence on single-use disposable items, reducing our resiliency. And so we tend to be aware of who our direct suppliers are. We know who they are. We have no idea who their suppliers are and who the suppliers of those suppliers are going back. In fact, we can rarely get past one tier of understanding. And this lack of transparency is part of the vulnerability, and particularly in the as we're talking about single-use disposables in the pandemic. And globalization can be a good thing. It reduces production costs and storage costs. It also reduces local pollution if something's made elsewhere, but it's increasing pollution and can lead to unfair, unjust wages in other countries. And so there's a question about justice here. And again, this lack of transparency is leaving us quite vulnerable, and whether it's a pandemic or climate change, where a factory is taken out, a critical factor is taken out, as we've seen with Hurricane Helene and Hurricane Maria. This lack of transparency, this lack of is leaving us all vulnerable. And so digging deeper into this infection prevention control issue, I'm going to give one example. One type of infection is surgical site infection. If you go back in history, say 1800, and you had a surgery, it was, the clean contaminated wound, say a leg amputation, you would have about a 95% chance of getting an infection and a 40% chance of surviving. Now along comes Semmelweis and Pasteur and Lister, so germ theory, antiseptic techniques. So that's when we started doing sterilization and decontamination. And that's where you see this greatest contribution in the history of medicine, this big decrement in the infection rate, and great increase in the survival curve. So flash forward and you see another little blip here between the world wars, and that was the advent and the introduction of antibiotics. And so the next greatest advent in the history of of medicine in terms of preventing infections. And so now you see we are gradually approaching zero, aiming for zero harm, and you have less than a 5% chance of getting infected and greater than a 95% chance of 95% chance of survival. Now, but if you blow out the bottom of that curve, as we are asymptotically approaching zero, we are throwing more and more disposables at the problem and completely ignoring this rising increase in direct disease burden from healthcare pollution. And so we really have to ask the question is, zero healthcare acquired infections realistic? We can't ignore the indirect damages. I don't know what that best balance point is, but we are certainly way out of balance, ignoring what's happening in terms of impacts on public health. And in fact, the causes of infection are multifactorial. The biggest things that we know have to happen include staff discipline for antiseptic and aseptic practices, including hand washing, cleaning, draping in the case of sterile procedures. And the other second biggest contributing factor is the patient health status. Are they frail? Are they immunocompromised? Do they have diabetes? Do they have an autoimmune disease, either uh, from medications they're taking, for example, for cancer medications, steroids, and so forth? So those are the two biggest contributors to healthcare acquired infections. Other things, of course, the exposure site, the type and quantity of organism, whether or not they got appropriate antibiotics, and so forth. But what we're not going to do is fix a patient's immuno health status by more and more disposables. And we're not going to fix a dirty room by throwing more and more disposables. In fact, you can contaminate a brand new, clean, even sterile device with dirty hands. Just because something is single-use disposable does not mean you aren't going to cross-contaminate. And so we really need to be mindful about what the interventions are to prevent healthcare acquired infections. And it's not just simply single-use disposable items. And now we've got this other issue of plastic pollution. If we continue business as usual, by 2050, there will be more plastic by volume than fish in the ocean. Um, and it's not just accumulating on the top. If you've heard of the great garbage patches, and now, there's this new technology to safely skim it off the ocean. There are other problems, including it's not just on the ocean, it's also at the bottom of the ocean as well. There's no waterway in this world that has not been found to be contaminated, even in the Mariana Trench, miles beneath the surface, there is plastic contamination. And the issue is not just macroplastics, but microplastics, now nanoplastics, that the plastics just keep breaking down into smaller and smaller pieces. And by the way, they are 97% made out of fossil fuel. So it's made out of oil. So this is being driven by the same industry that is contributing greenhouse gases in the manufacturing and disposal of these products. They are made out of fossil fuels. And they don't go anywhere. They just break down into smaller and smaller pieces. I can't even keep up with the literature anymore. So microplastics are ubiquitous in our tap water, ubiquitous in our table salt globally. They're found in human stool. They're found in wild animal stools in remote locations. They're found in our lungs and blood and semen and umbilical cords and breast milk. And also crossing the blood-brain barrier, so now nanoplastics. And it's not just the plastic itself, which can cause immune reactions and as well as physical obstruction, but also these plastics are laden with chemicals that then so we're essentially seeding our body with these chemicals, and we don't even understand all the effects we're having. So common ones, so plasticizers, so chemical additives that impart desirable properties, so flexibility, transparency, so your IV tubing, your IV bag, so desirable properties, but they're laden with chemicals that are ionically bound that just leach off. And so a single exposure to IV fluid, you can measure these endocrine disrupting chemicals in our urine, which is why there's now this movement toward phthalate-3 plastics, at least in neonatal units and maternal units. But they don't address look-alike chemicals. So simply banning one chemical, one that is almost similar, can be easily identified. So phthalate-free is not enough. And of course, it's not. There's also other things to worry about with plastics, including the production, which is very energy intensive, and then eventually the waste disposal, which a lot of waste is just simply getting incinerated. So we're burning it and then liberating a lot of toxins of concern. Or if they end up in landfill, then we're leaching those impregnated chemicals as well. Um, and the healthcare costs of plastics have been calculated globally, nearly $600 billion globally, and in the US alone, nearly $700 billion in damages from plastic. And this information is taken from a report that came out earlier this year, last year, the Mindoro Monaco Commission on Plastics and Human Health. I highly recommend this report. If you're following this subject at all, there is many iterations and work toward a UN Global Plastics Treaty is expected to be ratified by the end of this year. However, healthcare has been exempted, right? We get this pass to pollute because taking care of patients is a priority, and that really needs to be addressed. So there's a whole group working to make sure healthcare is not exempt from this. That's not to say there's never a use from plastic, but there has to be intentionality in reducing this plastic and reducing this pollution. So I'm going to give an example from my own practice. This is what's called a laryngoscope. We use it we put it in the mouth. This is called the tongue blade. This is the handle we hold on to. We put it in the mouth to pull the tongue out of the way to see where we're going to place our breathing tube to put it in the trachea to keep patients asleep while they're critically ill or undergoing general anesthesia. And there was this problem with the infection prevention guidance that industry really jumped on, where and I'm going to delve into this, but the mouth is dirty. We know that the tongue blade goes in the dirty mouth. Your hand is not sterile. Your hand is dirty, but there is unclear guidance on what level of cleaning this is. And so, just to make sure we were compliant with regulations, there was this massive wave to go to a single-use disposable laryngoscope. Either increase the cleaning requirements of the handle, or go to single-use disposable. So everyone said, well, it's easier, let's just go to disposable. And so, I can use half a dozen a day of these things. And what you're seeing here is a device that the manufacturer said, this is recyclable, it's green. We're going to come back to that. So there are different options to choose from. My manager went with this one because the company said it was green and it could be recycled. What they meant by that is it could be recycled. Well, I assure you, this was not designed for recyclability. I had to break this apart. It wasn't designed to be disassembled, and we're certainly not going to be able to reclaim all these components, including lithium batteries, which 3-button batteries used for 15 seconds and tossed. It's really quite criminal, to be perfectly frank. So we're going to come back to that. So why did this happen? So let's come back to infection risk classification. So critical items, those items that contact normally sterile tissue. So if you're putting surgical instruments into someone's abdomen, it's normally sterile there. Those instruments need to be sterile. Those are considered critical items. Semi-critical items, those things that contact mucous membranes or non-intact skin, they don't need to be sterile. Your mouth is dirty. Something you put into that does not need to be sterile. When you eat at a restaurant, you're using silverware that someone else has used before, but it has been disinfected. So those require high-level disinfection. These two categories go down to the central sterilization supply department in the hospital. The last class here is non-critical items, things that contact intact skin, like a blood pressure cuff, or what you're seeing here is an image of an ultrasound probe. That's just going on your skin. Those things don't need to be sterile. They can actually be cleaned at the point of use. So you're seeing someone wiping down this ultrasound probe with a chemical wipe. So what's now happened is someone in their infinite wisdom said, well, we're really unsure about the handle because it touches the tongue blade. We know the tongue blade is semi-critical, and historically goes down to central sterilization and supply for decontamination. The handle just touches your hand. So therefore, historically, it was cleaned at point of use, low level, low risk cleaning. Someone in their infinite wisdom said, oh, but they're touching each other. They're touching each other, and therefore the handle should also be considered intermediate risk. And so your choices are, now you have to create a whole system of sending this handle down to your central sterilization supply department. So you got to collect it, create a whole process for them to decontaminate it, send it back, or just go to your disposal. And this, by the way, is an oversight group coming in and saying and citing you if you don't handle this quickly. So we saw this wave across the entire country of switching to disposables. And again, this is based, and also we went with our device based on essentially a greenwashing claim, the practice of making unwarranted or exaggerated claims of sustainability or environmental preference in an attempt to gain market share. So with our environmental engineering students, we did a project, a life cycle assessment. So we know that I reviewed all the infection prevention control literature. There's absolutely nothing to support this argument that the handle needs to be intermediate level cleaned. And so as long as you can justify, you can actually push back on the oversight bodies. But we also just wanted to do a deeper dive into the environmental emissions and costs. So we did a life cycle assessment study, which is a modeling tool to quantify the resource and energy inputs and then the environmental burden outputs over the life cycle of a product or a process. So we tend to think about stuff when we use it. Mostly that's the only time we think about it. We tend to not think so much about what goes into the making of that product or the raw material extraction to then make the product. Maybe we think about a little bit what happens when we throw something away. But to make environmentally informed choices, you have to look at the entire life cycle to be able to make either improvements during any of these phases, including how you throw things away or how you make them, or in choosing between products. And so you have to consider the whole system to make an informed decision. Just because something is recyclable, is that really green? We don't know. We have to do this study to find out. And we have to look at multiple environmental impacts. We talk a lot about greenhouse gas emissions, but it's not the only impact and concern. So we have to be very careful that we're not just shifting one problem for another. And so we use this to inform design and decision, procurement and utilization support. So we did this life cycle assessment of the laryngoscopes. We looked at the single-use disposable. So one, raw material extraction, manufacturing, packaging use, and one disposable compared to one use of a reusable. In this case, the reusables are rated for 4,000 uses. So that means one extraction, manufacturing, packaging, use, 1/4,000th of the manufacturing, one use, one cleaning, one repackaging, and 1/4000th of this of the disposal. So you have to make sure you're comparing like to like. So that's a way that decision makers are fooled. And then we also looked at costs, including the refurbishing and the cleaning costs and disposal fees and so forth. So looked at costs and looked at impacts. And there's a lot of information here. So just squint at it, some big ideas. So on the left, the emissions, we looked at both plastic and stainless steel disposable versions. The green are different approved cleaning scenarios of the reusables. So high level disinfection versus sterilization versus low level disinfection. We looked at the handles and blades separately. And if you just squint at it, the first takeaway here is that the gray is much bigger than the green. The gray are the single-use disposables, so more than a 7-time difference, more emissions coming from the single-use disposables on a life cycle per use basis. Now, we also looked at waste management. So the red is the waste disposal management, and when we modeled it, we considered the average US energy mix. In this case, we know there's a national average fraction that gets recycled, a fraction that gets landfilled, um, a fraction that gets incinerated. So we use the standard US energy mix in this modeling. But what if, for the sake of argument, now there's no way we can 100% recycle those components, but what for the sake of argument we could? That's what the black bar you're seeing here. So we tested the manufacturer's claims that this was a green product, a green solution, that you should go to disposables. And the takeaway here is that we cannot recycle our way out of this problem. On the right, now this obviously is very institution specific. We looked at the annual costs in just my department and found by switching to disposables, we increased our cost by over $600,000 a year. And in fact, because we already we process about 12,000 instruments a day on average in our institution, this would add maybe 1% more to the daily load. So we would not have to add more staff, but if we did, we could do so and afford to do so and still save money across the organization. So also a lesson in not looking at silos, because it'll increase the cost of that one department, but overall to the institution save a lot of money. And this story is not, this is just one device we looked at. Here's a similar story looking at PPE, the protective gowns. And so there are reusable versions. And so this was a review, a meta-analysis looking at different studies on the environmental impacts of textiles, and found that single-use disposable gowns use 2 to 3 times the energy of reusables, 7.5 times more solid waste, 2.5 to 3.3 times more water consumption, and 2 to 3 times more greenhouse gas emissions to use disposables versus reusables. And so there are numerous studies looking at medical products. Now, where you do the study matters. Now, we tend to all buy our stuff from the same global manufacturers, but when you're cleaning something, you're going to use your local energy. And so this was a study by a colleague of mine in Australia, demonstrating that if you compared a reusable item to a single-use disposal in Australia, where they're heavily reliant on brown coal, in fact, the reusables had slightly more emissions than the single-use disposable version. Versus if you did the same study in the United States, the reusables had far fewer emissions than the disposable, and in Europe, where they had even more renewable energy than in the United States, even more favorable to use reusables. So does this mean that in Australia, they should be using single-use disposables? No, it means that they need to clean up their energy source. And in fact, we, need to look to more renewables. So that's a clear take-home message. We really need to ask the question, what is a disposable medical device to even begin with? SUD, or single-use disposable device, that is actually an industry designation. It's not a regulatory designation. What it has come to mean is that whoever cleans that device is legally responsible, that it functions as if it's new. It does not mean that a device cannot be reused. And that's really critical. And in fact, we have a third-party industry where single-use disposals are collected by a third party. They are clean, tested for safety, remanufactured, repackaged, and sold at a considerable discount. And whoever does that, and it's a highly FDA regulated process. And so they are assuming the risk. So we actually do this quite commonly. And what you're saying, like during the pandemic, where these devices were not designed to be reused. So the N95 respirator masks, our personal protective equipment, our contact gowns, or again, this laryngoscope, you're seeing a video laryngoscope version, so a different variation on a laryngoscope to put that breathing tube in. You're seeing versions of disposables that we had to figure out and how to clean and do so safely under the Emergency Use Act, under emergency conditions. And we figured out how to do so safely and to reuse them. But we also have reusable versions, and it really begs the question, what even is a single-use disposable device? And we really need to question that and question the assumption that it is cleaner and safer to just use disposables. Because actually, for things that are difficult to clean and are cheap to make, intravenous catheters, syringes, we're not going to try and reclaim those and reuse them. Although there was a time in not so recent, not so distant history where we did so. We don't need to do that now, but by and large, we are out of control. Disposable blood pressure cuffs, disposable laryngoscopes, disposable complex surgical instruments. It's really rather insane, and it is not based on evidence. And so we have to, what we have is called a linear economy, or the take make waste economy, where we extract materials, we make something, we use it, and then very briefly, then we throw it away. So that's called the linear economy. In nature, there is no such thing as waste. The waste product of one system is the feedstock for another. So the circular economy based on nature principles is really what is now becoming principles for how we transform our economy and transform society. The highest level thing is we need to retain and reuse something as long as possible. When that's not possible, then we have to repurpose it for some other indication. Then the last thing you really want to do is recycle. It's probably better than nothing. Even that is debatable. But it's not the first thing that you want to do. And in fact, even moving upstream to redesign stuff so it has less materials in it and is designed for durability and has safer materials, those are really the things that need to happen. And we need policy drivers to move us away from manufactured obsolescence. In the interest of time, because I've been talking a long time, I'm going to skip this next subject. And just to say that there is this movement to net zero healthcare to reduce the emissions embodied in the healthcare system. So I showed you that wheel earlier, the wheel diagram. Here is taken from the National Health Service in England, which is a global leader in sustainability, and what they've done. And this is through a legal mandate. But not only have they benchmarked their emissions, but before there was a Paris Accord, they had their Climate Act of 2008, where they committed their nation to have emissions by 2030 and get to near by 2050. That includes every governmental organization, including their health service. So what did they do? They created a whole division to measure their health sector emissions and to institute practices to mitigate those emissions. And there's not one solution. So what you're seeing is all the problem areas and known solutions that some go quickly, some are going to take years to institute, but that they projected what it's going to take to get to net zero by 2050. And now this slide is already a little behind. More than 80 nations have committed to the COP26 health program, which again is in alignment with the Paris Accord. How do we get to net zero healthcare? There's a WHA group that is overseeing this initiative called ATTACH, or the Alliance for Action on Climate and Health. So there's a lot of global activity of healthcare systems, not only committing to these goals, but also sharing their best practices, sharing their learnings. Here in the United States, there's a White House pledge. The Joint Commissioner Oversight Body has a sustainability certificate now. And CMS, which funds half the healthcare in the country, has created this decarbonization and resilience initiative, which in short has voluntary emissions reporting and mitigation for 5 years. And if you read the fine print, after 5 years, it's going to become required. So we are voluntarily moving in the direction, but not quickly enough. Voluntary measures cannot get us fast enough, far enough. I firmly believe this has to be regulated. And things that I have not spent much time talking over, and that is moving upstream to disease prevention and better chronic disease management. So keeping patients healthier and for as long as possible to begin with. So having more green spaces, facilitating more active transportation, physical activity, making it easier to shift to a whole foods plant-based diet, addressing the social determinants of health that people can afford to pay the rent, that they can afford food, that they have access to energy and heating and cooling and transportation. So really making sure that people have what they need to thrive, and expanding and having more affordable primary care. So this is a whole area to address. And this really fits into back to this planetary health, and as it applies to health care. We published a planetary healthcare framework. So three different buckets here that we've talked about to various degrees. Reducing the emissions embodied in healthcare products and services. So moving to electrification and clean energy, so that's something that happens outside the health system, but certainly impacts the health system as being a large drawer of energy. Shifting to the circular economy and being better resource stewards as clinicians. We can do the same good care with too much stuff or just the right stuff. So we really, and those of us who take care of patients, know that we're dripping in wasteful practices. Matching supply and demand. So that means delivering care that is appropriate, needed, wanted, effective, and so forth. We know we have one fourth of health services globally, one-third in the United States are deemed inappropriate or low value. We know it's a problem. We need to address that. And then again, moving upstream to reduce demand for healthcare services to begin with. So health promotion, disease prevention, addressing the social determinants of health. When we think about value in healthcare, we talked about the triple aim, the best care for the most patients at the least cost. So least cost is not just financial cost, it's also environmental and social as well. And with that, I'll take questions.
Thank you. Thank you so much, Jodi. I am trying to open my camera. Let me try one more time. There we are. Thank you so much, Jodi. That was an incredibly dense presentation, and I don't know about everybody else on the Zoom, but I was very regretful of the section that we missed. So what that means is that we'll have to have you back for another presentation, because lots of really valuable and insightful points that you've raised here. We have quite a few questions. We've got some good comments in the chat. So for those of you who were sort of engrossed in the presentation as I was, please do take a look at the chat, some interesting comments there. One that I want to highlight is Thomas's comment, who says that he plans to share this in his medical and climate change circles. And I point that out because this presentation is being recorded. The recording is available after the presentation is over. It may take us a day or two to get it up, but it is on the alumniacademy.yale.edu website under our 2024 Climate Change Conversations series. There are also some resources that Dr. Sherman has shared, and there was a question, Jodi, whether or not you would be happy to share your slides. So as
Yeah,
long as you're
sure.
okay with that, the slides will be posted on the Alumni Academy website as well. So we'll send that link out to everyone who's registered for the presentation when the recording is available. So we do have opportunity here for some conversation, some great questions raised in the Q&A. I want to go to those. Some of the points I think you touched on, but we can get more deeply into them. I want to start with Jessica's question. Jessica asks, has your research explored how socialized medicine compares to for-profit healthcare systems, such as in the US, in terms of waste production and greenhouse gas emissions? Are there notable differences, or are the environmental impacts similar? And I'm going to sort of piggyback on that question in noting that in your emissions chart that you showed, I noticed that France was sort of an outlier as the opposite of the US. And I wondered, what is France doing? They had such great outcomes and among the least of emissions in that chart. And I believe theirs is a socialized medicine system like Jessica's referring to. So would love to hear your comments on those.
Yeah, so two things. We've sort of been operating under the assumption that, well, firstly, what distinguishes the US from all other high income nations is the fact that our health system is by and large private in nature. So it stands to reason that there is a direct relationship, certainly with why we are so bloated and wasteful, and it is, even with the Affordable Care Act, we still have a highly privatized healthcare system. So that is an obvious thing. Yet there are countries that do have robust private elements. Germany being one of them, Sweden being another, which is um, relatively green, but definitely not centrally managed. And so it's not as simple as private versus not, but we certainly believe that it is a huge problem. And in terms of France, what they're doing better, the predominant reason is because their energy source is largely nuclear, so it's cleaner to begin with. And so, whether nuclear is certainly cleaner, certainly we have other issues of concern with nuclear energy, but it's not that their healthcare is necessarily better. It may be more efficient than ours and may be better in some areas, but what they're doing better, it's not so, predominantly because of their energy source.
Really interesting point, because it's not the instinctive point, right? That we need to look at the energy underneath all of this. There was a question that actually touched a little bit on, let me see if I can find it, on medical facilities and their energy factories or their plants where their energy sources are. And I wonder if you could comment on this. It's Anne's question. What issues need to be taken into account when considering closing down on-site hospital fossil fuel plants and replacing them with renewables? Do certain high-tech diagnostic equipment and types of patient care make a transition from fossil fuel-based power plants to renewables? Is that challenging to do? And is there a movement afoot among hospitals to replace on-site fossil fuel plants with renewable alternatives?
Yeah, so I just let me preface my response by saying I'm not a facilities energy expert by any means, but what I will say is that I don't know that there's so much that the energy generation is on site. Um, versus pulling from municipal plants that are dependent on fossil fuel, but you can do on-sites, like solar installations, or they can be off-site and then through power purchasing agreements go back into the grid. So, or you can diversify and essentially have microgrids, which actually increases your resilience. So, um, in terms of the equipment in that transition, I think that um, energy is, I'm going to try and simplify. I mean, I kind of think energy is energy. So you just have to make sure you have energy flowing to make that transition. So that shouldn't impact, so I'm going to say your MRI machine. The source of the energy shouldn't matter. But if you're going to start electrifying your equipment, that's a different thing. So I don't know that. So if you have equipment on site like boilers that burn diesel fuel, like that's something on site that could be converted to converted to electric heating, or you could do district geothermal is something that's starting to become more prominent. So I don't know that I'm exactly answering your question, but I would say that most of the stuff we already use in the hospital, much of it is electric with some exceptions. And so it's the source that's going to change, and that can be pretty seamless. But there are other things that would be converted to electric. And so, you're right, you have to make sure there's a seamless conversion. But and a lot of this is through routine upgrades. So rather than just, flat out, let's just replace it. Nobody can afford to do that. So it's when it's time to upgrade things, just like in your house. Like, I have, an outdoor air conditioning unit. I want to switch to electric pumps, electric heating, electric cooling. And I was advised to wait till the natural lifespan ends. So that's when I do my upgrades. So similarly for hospitals, they can't afford, they have budgets based on how the life of capital equipment. And so we'll do those upgrades when the time comes, and can do so in a more environmentally sustainable and resilient way. But with new construction, you can get it right to begin with. So hopefully that helps.
Definitely helps. A next question I think is a good one to go to is Rachna. I hope I'm saying their name correctly. Rachna asks, I'm a clinician and I've started these conversations where I work. Someone asked why clinicians need to be involved. And they've said that this is more of an engineering problem. So speaking about energy sources is perhaps a more of an engineering problem. But Rachna's point of view is that clinicians need to be integral to these conversations. And the question is, how can I convince the folks where I work that we should be a part of the solution? They understand the effects on healthcare, but not our role in working to solutions.
Yeah, well, thanks for that great question. And there was a paper that I published, and maybe one of the YAA staff can pull it up in the BMJ British Medical Journal back in 2022 called Getting to Net Zero. What can net zero healthcare? What can clinicians do? And it really talks about our role on micro, meso, and macro scale. So the micro scale is what we can do. Like not everybody, every clinician may, I'm making it up. Let's say every clinician cared about climate change. It doesn't mean that that's going to be how they expend their energy. But if they're not going to become activists and try and change climate policy, for example. But there's something everyone can do in their daily practice. I already pointed out that 80% of our emissions come from the supply chain. Overall, about 25% of emissions are coming just from medical devices and pharmaceuticals, things that we have direct control over as clinicians. So we get to decide between clinical care pathways, which was a topic that I passed through the slides on. If you have two effective ways of treating the same condition and one is environmentally preferable to the other, then make the environmentally preferable choice. Same for devices, same for drugs. So if you have that information, you can make environmentally informed choices as a clinician. You can also be less wasteful in your practice. We are so wasteful. I mean, I go out of my way to not be wasteful, and I'm still wasteful. So there's something every single clinician can do in their practice. That's at the micro level, and how we teach and set examples for those around us. Those are actions at the micro level. At the meso level, we can get involved in our healthcare, in our hospitals, our healthcare organizations, get a leadership role, working with the procurement division, working with the energy division, creating a green team. Like you may not have this expertise, but those around you do. Create a green team. There's now a movement to create a whole new position called medical director of sustainability. I'm losing count because it's becoming such a popular position now. There's probably at least 20 in North America that I even know of. So it's a growing position, medical director of sustainability. So you can argue for that and create an infrastructure and have a green team with representation of every single operational, administrative, and clinical department to find out what everyone can do that is within their purview to do their part. So you don't have to be the expert on everyone, but everyone has to do their part. So that's at the meso level. And at the macro level, what can you do? At the state or the federal level, get involved with your professional society, create a guidance document, address outdated policies, get involved with state and level healthcare policy. Like I showed you what's happening through CMS, the Centers for Medicare and Medicaid. That didn't come out of nowhere. That came out of clinicians advocating, we need to make a change here. What's the lever? The lever is mandated reporting and mitigation. Who's going to make that happen? The people who are paying hospitals. Who is that? So that's how that happens. Everyone can do something and get involved.
Well, to that point, I want to go to Jessica's question because you just spoke about sort of the balance between activism amongst clinicians and on the local and state level, and then sort of federal intervention is what Jessica's getting at. She asks, in your opinion, from your research, would a universal healthcare system in the US lead to a more streamlined approach due to federal oversight, a streamlined approach to things like waste disposal, material usage, related processes?
Yeah, well, I would say it's a very hard question to take in our current political climate, to be just perfectly frank. But the closest thing we have to universal health care is CMS, Centers for Medicare and Medicaid. That's the closest thing that we have. It is a form of universal health care because at some point, if you are infirmed or old, you will have access to care. Now, obviously, we can and need to do better. I mean, I am all for a single payer system, but that's probably unrealistic certainly in any foreseeable future in our political climate. But those national health systems that have national nationally managed things like supply chain, they do a better job because they've got, here's your budget, this is what's approved by your government. You got to figure out how to use it as efficiently as you possibly can. And that is a very important lever to make these decisions. So I mentioned the NHS. Another one that is doing this is Australia. And so essentially HTH health technology assessments are the tools that governments use to assess what it is they're going to buy. And that is a very important lever.
Well, I want to follow that up with Judith's question, asking, you named a couple of examples internationally, but I wonder if there are any regions or states in the US that are doing a better job of providing care with less waste or fewer environmental effects. Any good case studies or standout examples in the US?
Yeah, I appreciate that. We have done a couple of publications on the U.S. healthcare systems impacts. The most recent one, we have one under review now, but the most recent one that's in print is from 2020 in Health Affairs, where we not only looked at the national level, but we did look at the state level, and we looked at emissions, but we also looked at healthcare access and quality. And there are some outliers there, but not in a way that I would say. And we also looked at the impacts of the expansion of Medicare, thinking that that would be quite revealing for that very reason. And the effect was not really detectable, not yet anyway, not when we looked. That said, there are a few states who are moving in a positive direction, just sort of differently. And I would say Washington State, California, Massachusetts are and Oregon are the big outliers, including having the big thing I think right now is so critical is requiring that healthcare organizations report their emissions and then to have a strategic plan to mitigate them. If you're not reporting the emissions, firstly, it's really not hard to do. People have to get over the hurdle that it's hard to do. It's not. But once you report the emissions, then you can come up with a strategic plan, which by the way, everybody wants to cut waste and save money. And a big motivator for many employees, particularly clinicians who tend to care less about the money and more about the health care and public health impacts, that you can really engage staff around this. But in order to strategically prioritize based on impact and feasibility, you need to know where those emissions are coming from. And so those states that are have some requirements for reporting are the ones that are most advanced, so the ones that I mentioned.
That it seems like it could be a whole additional presentation. How did they get those requirements in place? What kinds of advocacy helps to achieve that? And I'm so curious, but I'm not going to go down that path. I'm going to switch to Kathleen's question. Kathleen says, have any medical societies expressed interest in picking up these approaches? So we just talked about state examples. And Kathleen is wondering if there are societies or organizations. She names Physicians for Social Responsibility as having done some work on it. Yes, yet it seems a concerted effort is needed, says Kathleen.
Yeah, so Physicians for Social Responsibility. There's also there's an umbrella organization called the Medical Society Consortium on Climate Change and Health. Those are primarily advocacy groups, so really trying to affect policy that's going to improve public health. So in the case of the Medical Society Consortium on Climate Change and Health, their big goal is to help transition the US off of fossil fuels. So that is their big advocacy push. Um, Now, I mentioned like that could be part of a macro action, but there are things that need to happen on the meso and the micro scale of things. So the healthcare delivery piece, and there are a number of societies that are doing work and that have. So, for example, my own society, the American Society of Anesthesiologists, and also the World Federation of Societies of Anesthesiologists, we have sustainability committees and have passed policies and statements and have requirements and education now just at the beginning, but they are there. And so it's and there's also Annie, which is I forget exactly it's a big nursing society is doing a lot of work in this space. Again, it's more on the advocacy and large policy, society policy piece. but there is a lot of activity happening amongst specific clinical societies, and there needs to be even more action. So I'd say if you're a clinician and interested in this space, that you look to see what your organization already has going. And if you may be surprised that there is activity you weren't aware of, and if there's not, then I encourage you to get involved and start it up. I assure you that you will not be alone.
Well, let's shift from that to what's happening at Yale. So Kate asks, I would love to hear how Yale has been doing with implementing some of the work that you've highlighted. Kate says the anesthesiologists I work with would love to shift away from single-use laryngoscope blades. I hope I'm pronouncing that correctly.
Mhm.
But it's an uphill battle to bring infection prevention and control and our sterile processing department on board.
Yeah, so it's say, at Yale, well, we have to sort of differentiate. There's Yale University, and then there's Yale New Haven Health System. They're separate entities. I work in both of them, but just want to clarify they are separate entities. And it sounds like you're asking a question about Yale New Haven Health System. So I will say that the laryngoscopes are a real challenge. Now, I did that study because of a change that happened back in 2013, published that paper in 2014. And so my institution quickly switched back to reusables after having switched to disposables based on this study. Now, flash forward since the pandemic, we and everyone went to disposables, and for good reason. Having our face in a patient's face is definitely very high occupational risk. The challenge is we not shifted back, and it is very true that you need your infection prevention team on board, you need your central sterilization supply department on board, and this is where it helps to be part of the professional society group to understand who's done what, so you can take those examples and say, yes, this is being done, we're not reinventing the wheel. Get on board to help move your organization. And I wish it were easier. It's not easy, but it we have to continue.
Yeah, I often have thought about if a future society on Earth is doing an archaeological dig, 1,000 years from now, they're going to get to a layer for 2020 to 2022. That's just all disposable masks and all the things that we produced in abundance during the pandemic for infection prevention without really thinking about the life cycle of those items. So I think it's a really important point that you're making. We had yesterday a presentation from Julie Zimmerman, and Yale Planetary Solutions, and she was speaking with Sarah Smiley Smith about identifying which foods were most abundant in the dining hall waste stream and using AI to do it, and then working backwards to figure out why this waste was being produced and how purchasing could be streamlined to avoid buying something that was actually just ending up being thrown away. And so Anne is asking if this could be applied, at least on a pilot basis, in hospitals using AI to break down the biohazard bag contents and other healthcare waste streams and prioritize which products to address with suppliers first.
Um, yeah, I mean, in theory, we could do something like that. Sure. I mean, I also, Professor Zimmerman is, a very innovative and bright thinker. I would say that the it's very hard to get a hold over our healthcare supply chain. Enormously complicated, far more so than other industries or products. Very few of them are very few of them are simple products. Many of them are highly complicated composite products, and um, and we cannot afford interruptions, and we have very strict oversight. Um, in theory, could all this be handled with digitalization? The answer is yes. There's also a big challenge of AI having its own footprint and huge energy draws. So I'm not sure if that came up in that conversation, but sure, in theory, I think it's all there and it's the wave of the future. The how we're going to get there, fast enough and sustainably is I think an ongoing question.
Some really interesting points that have been raised in the questions about, people speaking. For example, Kathy says, I use a CPAP machine and the amount of waste involved is shocking to me. Medicare allows the component to be replaced pretty often, but I can't tell if those recommendations are evidence-based or not. We had someone else asking about using paper and bamboo products rather than plastics, whether that could be a good approach. Um, and the question I want to pose out of this sort of category of comments that have come up is Jeff's. Jeff is asking, do you know of any hospital group purchasing organizations that focus less on a less carbon intensive supply chain?
Yeah, okay. So one by one, the question on the CPAP machine, why you get to replace components when you do, I can't answer. I would say that it probably largely depends on who advocated for it, including industry themselves. Because the more turnover of components, then the more money they make. So it could have come from a patient advocacy group. It could have come from industry itself. So whether or not you need to replace things as frequently as you do, even if they're paid for, I don't have the answer for. I know when I had knee surgery, they asked me before I went home, do you want a walker or do you want a cane or do you want crutches? And like, I don't know, I didn't have surgery before. I said, I don't know. And I didn't know any better. I said, could I have both? They said, sure, why not? So they gave me both without question because insurance paid for it. Now, in retrospect, I wish I didn't do that. But just an example, like it's complicated how things are paid for, and industry has a large role to play in what gets paid for. In terms of paper or plastic, now this is a really interesting role for life cycle assessment, because in fact, if you can get more uses out of something, there's a classic question of a paper bag versus a plastic bag. It turns out that the paper bag that you use once and throw away is very energy intensive and it has more embodied emissions than a plastic bag that you use twice or whatever the break point is. So now there are other types of pollution concern for that plastic bag or a canvas bag or a metal to go where. I mean, we had to work very hard to get our professional societies to stop giving us mugs and bags, every time we have a meeting. I don't know how I've managed, but I have like one canvas bag that I got when I was an undergrad student that somehow is, it's got holes in it, but somehow it's still thriving. Um, but like a metal to go mug, which, I've gotten so many that I've lost them. I'm sure like others have had this experience. You have to use it hundreds of times to break even with a to go cups. So it's paper, something that's made from natural materials seems like it's better. Remember, there are trade-offs, and so it's not as simple. But can we, incinerate a plastic bag, waste of energy? Can we, that may be a more viable solution than using it and incinerating a paper bag. So the questions are not intuitive. The answers are not intuitive. And then the last question, sorry, remind me again.
The last question is there a supplier, a healthcare supplier that
Yes.
you could
Yeah.
purchase from that cares about these
Yeah.
issues?
So there are numerous groups right now trying to, well, there are very large group purchasing organizations, which it's very important because you can use your purchasing power. This is the NHS being the largest health system in the world, was it 60 million some odd members? They have considerable purchasing power, and so they've created a very strict procurement policy that requires their vendors of a certain tender size or above to participate in ESG reporting, so standardized, transparent reporting and mitigation according to science-based targets and timelines of Paris Agreement. And so they require, if you want to do business with us, you have to be reporting and third party verifiable. You can't make it up, right? In a standardized way and drawing your emissions down if you even want the opportunity to do business with us. And now they're moving toward requirements for product level reporting. So not just how you're doing as a company, but what are the emissions embodied in your product, to try and get away from this greenwashing business. Like, go with this laryngoscope, it's greener because you can recycle it. So that's the direction we have to go, and we have to leverage our power together, sign on to these policies and employ them. Now, there are supplier groups, and there are suppliers who are trying to do the right thing, and then there are suppliers who are participating in greenwashing, which is why we need standards. So the Securities and Exchange Commission was the closest thing we had to standards, but of course that didn't succeed as rigorously as comprehensively as we wanted, although laws in California are quite rigorous. So if you're a company wanting to do business in California, you have to report and mitigate all scopes. If you're familiar with the language, scopes 1, 2, and 3. So there are vendors trying to do the right thing. There are regulations that are driving things in the right direction. There are groups using their purchasing power to help drive things in the right direction. There are also countering forces of industry getting together and trying to say what the standards ought to be and to obfuscate and slow things down, because it's going to require investment on their part, and they may not appear to be the best in the end. And we really need to counter those forces, because we cannot afford intentional or unintentional greenwashing.
That seems like a perfect point to end on. Thank you, Dr. Jodi Sherman. This has been a powerful presentation, very rich with content that I know our alumni community can and will use in their professional and personal circles. I hope that we can have you back again to talk about all the things we didn't get to cover today. I want to remind everybody here that this is the second of a series of climate change conversations. There are 6 in total during this, our 5th anniversary year. Our next on Wednesday, November 20th at 5 p.m. Eastern is Listening to Climate Change, Building Student Advocacy, presented by Judith Lichtman and Matthew Sutter. So I hope those of you who are available will tune in. All of these recordings will be available on the alumniacademy.yale.edu website, along with useful links to resources, readings, presentation notes, etc., that you can use and download. And with that, I will put it back to you, Jodi, to give a last word if there's anything you would like to say before we depart.
I guess the big take-home message is that everyone can do something, and everyone should be doing something. And I hope people feel inspired to get involved and to do their part. And I'd be delighted to take any emails or questions after. So thank you very much again for the opportunity.
Wonderful. Thank you. Have a great day, everyone. We'll see you on the next presentation. Thank you again, Jodi. I hope to see you again soon. Bye-bye.
Thanks so much. Bye-bye.